Hello, everyone. Good afternoon. I think some people are still joining. I see some people still coming through the lobby, but in the interest of time, I think we will get started. So thank you so much to everyone for joining us today for this webinar on health financing and social health protection for rare diseases. We have a great lineup of speakers, and I think it'll be really interesting. So without further ado, I will start the presentation. Just wait, giving a second for the slides to come up. Okay, hopefully everyone can see the slides. So just going over some housekeeping before I introduce our opening speakers. We do ask if you can add your name and organization. Feel free to say hi in the chat where you're joining from. If you have any questions throughout the session, please write them in the chat or use the question and answer function, the Q&A function. We are recording the webinar, which we can share on YouTube after for everyone to access. And in line with RDI's policy, we ask that there's no AI note takers in the meeting unless you need them for accessibility purposes. Feel free to let us know. And lastly, I just want to mention that Microsoft Teams has a live text translation option. So at the top of your screen, if you're on the app, you should see 3 dots that say more. And if you click on that and then you click on language and speech, you can activate live captions. And then once you click show live captions, a menu should pop up on the right where you can select the language that you would like the captions to appear in. So there's a few languages available and they should be live translating what we're saying into the selected language. So if you have any troubles or issues accessing that, please let us know in the chat and we can try to figure that out with you. But hopefully that will help for the meeting. The agenda today, we'll open with some introductory remarks, and then we'll have a presentation on the overall findings of our analysis on health financing and social health protection for rare diseases from 11 countries. And then we'll have presentations from 3 case studies, and we'll pause for some questions. And then we'll open it up to our panel discussion and have some more questions after that. And then we'll wrap up with some conclusions and next steps for the project. So without further ado, I would like to introduce Claude Mayer and Alexandra Humber-Perry. Claude, did you want to go first from the P4H network and WHO?
Sure. Thanks a lot, Alana, and welcome to all the participants in this webinar. I would like to, first of all, really say thank you to Rare Disease International for the excellent collaboration that we had in preparation of this webinar and for the ongoing work that we have been carrying out together for like more than 1 year, 1.5 years. So a very big thank you on behalf of the P4H team to you. And of course, also a first comment on the topic that is, of course, health financing and social health protection of people living with rare disease. Our objective, the objective of the 24 members of the P4H network, the countries, the institutions, the academic institutions that are behind, is of course to work on improving financial protection in case of sickness. And of course, the people and the persons living with rare disease are vulnerable in many situations. So it is our mission in the P4H network to try to 24 institutions to find solutions to improve the financial protection of the people living with rare disease. And last but not least, I would like also to mention that in WHO we have published 2 days ago new guidance on the current health financing emergency that we observe in the world with a lot of cuts observed in many countries. And that, of course, this webinar is absolutely timely in the context that we're witnessing globally. So thanks a lot, and I hand over to Alexandra. Thanks.
Thank you very much, Claude. I think I'm going to echo some of your points, but again, good afternoon, good morning, and good evening to to all joining us today from different parts of the world. On behalf of RDI, I'm delighted to welcome you to this webinar on health financing and social health protection for rare diseases. Today's session, I would say, mark really an important milestone in our collective effort to make rare diseases an integral part of global health and social health protection agenda. We come together actually as a pivotal moment, as Claude mentioned, because the global health community is rethinking how to build a fairer and more resilient system. And I would say that rare diseases really offer a concrete way to turn words into action. We talk about universal health coverage, etc. Because by addressing the needs of persons living with rare disease, actually we make equity measurable, strengthen system for everyone, and bring patients and communities to the center of governance. So this project, conducted in a great collaboration with the Social Health Protection Network, P4H, hosted by WHO, and also our partner from 11 countries, really explores how national health financing system can sustainability and equitability respond to the need of people living with rare diseases. It highlights both the challenges, but also the innovative pathways being tested to bridge coverage gaps and make universal health coverage truly universal. So over the next 2 hours, as Alana presented to you, we will hear the preliminary funding of the study, some country case study as well from China, France, and Kazakhstan. And then we will have a panel discussion with some leading experts in health economics and policy. So together we will reflect on how these lessons can inform the implementation of the recent World Health Assembly resolution and the forthcoming Global Action Plan on Rare Diseases. So our objective is not only to share insight, but it's also to listen and learning from you. So your reaction and question will be very critical to us. Because we will refine the recommendation and the findings before we publish a report later this year. So thank you to all our speakers and partners for their contribution and their time, and to everyone attending for engaging with us on this critical topic. Over to you, Alana.
Excellent. Thank you so much, Alexandra and Claude, for those remarks. Next, I'd like to pass the presentation over to Aung-Somalie Volpark from the P4H Social Health Protection Network to walk us through some of the findings and analysis from the study.
Thank you, Alana. My name is Aung-Somalie Volpark, P4H Community Facilitator. It is my pleasure to be here today to present the findings on health financing and social health protection of rare diseases from 11 countries. Here is the outline of my presentation. I will begin with the background of this study, followed by method used in this study, findings of 11 countries, and challenges and further understanding that identified from our findings. First of all, I would like to give a brief background about this study. Although there is no standard definition for rare diseases, but a rare disease is often refers to a specific health condition affecting fewer than 1 out of every 2,000 individuals. Despite its low prevalence, rare disease often affects multiple organs, and this could lead to serious disability and premature death. Given the high cost of treatment and medicine for rare diseases, the absence of adequate social health protection can push people living with rare diseases and their families are at risk of falling into poverty due to catastrophic health expenditures. Therefore, effective and innovative health financing for rare diseases plays a crucial role to ensure that people living with rare diseases and their family are financially protected. Next, I would like to talk about the scope of this study. This study aims to provide an overview of health financing arrangement and social health protection for rare diseases in 11 countries that include United Republic of Tanzania, Cote d'Ivoire, Colombia, Costa Rica, France, Kazakhstan, Russian Federation, India, Thailand, Australia, and China. And I would like to point out here that the focus of this study is on treatment and medicine for rare diseases. Next, I will talking a little bit about method of this study. In terms of the country selection, the country were purposely select through the RDI and P4H network connections. And you can see here from the table that the 11 countries represent a diversity of income levels, health system structures, and regions. So this study begins with identifying the key informants who are experts on health financing and rare diseases from 11 countries. And then the data were collected through semi-structured interviews and questionnaire. And totally 18 key informants are included in this study. After we received the data was validated and analyzed based on health financing function that include revenue raising, pooling, and purchasing. And challenges were identified from findings of 11 countries. Next, I will go through the findings. You can see here from the table, you can see that rare disease definition vary across 11 countries. But you can see that the definition defined by the prevalence of rare diseases or the proportion of population who living with rare diseases. And you can see that the country have the operating definition for rare diseases, but it is not the formalized one. Only few countries like Colombia, Russia, and Australia, rare disease is formalized and state under the law. Next, I would like to talking about the social health protection of rare diseases. This table shows the different designs and level of social health protection for rare diseases. For the country like Cote d'Ivoire, Colombia, France, and Thailand, social health protection for rare diseases are provided under the National Health Insurance, and rare diseases are included under health benefit package. But there are also another model, which I will call it as a multi-layer social health protection, which can be observed from Kazakhstan, Russia, and China, which means that the basic health insurance or national health insurance is the first layer of social health protection. And the cost of treatment or medicine for rare diseases that are not covered by the national health insurance will be covered by other sources of funding or other social health protection scheme. And you can see more detail from our speaker from Kazakhstan and China. Another model that can be observed from this study, it is Australia. In Australia, the social health protection for rare disease is separate between treatment and medicine. For the treatment, it is covered under medical care, but for the medicine, it will be covered under pharmaceutical benefit scheme and life-saving drug programs. Basically, life-saving drug programs cover for medicine for ultra-rare disease that not covered by pharmaceutical benefit scheme that for high-cost medicine. And for India, there is an umbrella scheme of Rashtriya Arogya Niti, which is a financial assistance for rare disease treatment. And in India, there is a national crowdfunding platform for rare disease as well. And you can see that there is a country that include Tanzania and Costa Rica that currently the national health insurance has not yet include rare disease under health benefit package. And another thing that I would like to mention is about non-health social protection schemes. From our findings, we found that in some countries like Tanzania, France, Kazakhstan, Russia, Thailand, and Australia, they offer non-health protection scheme for people living with rare disease. However, the benefits is linked to disability status, which means that the rare disease is not directly make them eligible to receive the benefit. But if rare disease make they disabled or they become disabled because of rare disease, they will be eligible for pension and disability benefits. For example, in case of France, you can see from the table that financial assistance in several programs are provided to disabled people at different age groups. For example, the allowance for disabled adults, the allowance for the education of disabled children, and disability pension. And for Tanzania, there is a special needs education policy, which children with rare disease are included and and homeschooling is provided. And another thing that I would like to highlight is the example from Australia. In Australia, not only the people living with rare disease, but also their family would get the support. Under the carer support program, carers or family who take care of people living with the disease, they could receive the financial assistance through the social security system in case that they are unable to work because of care demand. And next, I would like to talking about revenue ratings. You can see from the table that most of the study countries adopt mixed source of financing for rare disease treatment and medicine. And government revenue and insurance contributions are prominent source of financing for rare disease in most countries. The exception is Australia, which mainly rely on government revenue. And in case of Cote d'Ivoire, Costa Rica, and Tanzania, out-of-pocket payments are predominant sources, and this reflects a limited financial protection for people affected with rare diseases. In addition, we found that in case of China, India, and Kazakhstan, they also mobilize private funding for financing for rare diseases. In terms of pooling, most of the study countries has no specific pooling for rare diseases and other life-threatening diseases. This is because it follows the general pooling of healthcare. But the exceptions were found in China, India, Kazakhstan, and Russian Federation, which I will explain in the next slide. But before going further, I would like to highlight here that in case of China, Kazakhstan, and Russia, they have finance for rare disease that cover for that include in general pooling of healthcare, and there is also the separate pooling for rare diseases. You can see here that China, India, Kazakhstan, and Russia has established the pooling mechanism for rare disease treatment and medicine for either people living with rare disease in general or specific group of population. And I would like to highlight that in China, China is only the country that established pooling mechanism for rare disease at the provincial level. That is Zhejiang provinces. And the contribution from each area in Zhejiang province will be the annual contribution based on the number of basic medical insurance enrollees. And current rate is at 0.3 USD per person. The rest of the three countries, the pooling mechanism for rare disease is established at the national or central level. For India, the umbrella scheme of Rashtriya Arogya Nidhi was set up to provide one-time financial assistance to patients living below poverty line and those who are suffering from major life-threatening disease, which means that this scheme this pooling mechanism is established to support the poor and vulnerable populations. And for Kazakhstan Hakina Foundation is established to support rare diseases that are not included under health benefit package. And therefore, for this foundation, it covers people living with rare disease in general. And it is funded by donation from legal entities and individual and local government budget. And the last case is for Russia, which is, I think, is also interesting because in case of Russia, the circle of kindness is established to support specifically to children with life-threatening chronic diseases, including rare diseases. And it is financed by individual income tax that allocate from the federal budget. And for purchasing, you can see from the table that the information on payment for providers are not available for many countries. But based on information we have, fee for service, fee schedule, and diagnosis-related groups or DRG are common payment methods that used to pay for rare diseases. And among the countries that adopt capitation payment, only Thailand that have the capitation payment particularly for rare diseases, while in Colombia and Kazakhstan, capitation is include all disease in health benefit package, including rare diseases. And another thing that I would like to mention here is that central procurement of high-cost medicine for rare disease has been already adopted in some countries that include Kazakhstan, Russian Federation, and Thailand. Next, I will move to the health benefit package. You can see from the table that the benefit coverage has a different level of generosities. The most generous and comprehensive one is from Australia and France. All rare disease can be reimbursed from the national health insurance. While the most of the country, rare disease in the list only that can be reimbursed or can be included. And I would like to note that in case of Colombia and Thailand, the rare disease that not included in the list will be managed through the national health insurance. And in Cote d'Ivoire, only sickle cell disease are included under health benefit package, while in Costa Rica and Tanzania, rare disease are not yet included in the health benefit package. While in India, one-time grant only provide, which means that the benefit is limited to one time, but not to the specific rare diseases. And another service that I would like to mention is about newborn screening, which is, I think, this very important services because newborn screening can lead to the early detection and can delay the progress of the rare disease or could prevent onset of the disease symptom, and this could reduce the children morbidity and mortality. And from the table, you can see that the country that offer newborn screening will be under two different programs. The first one is the national program, and the second one is the national health program, national health insurance program. Finally, I would like to highlight challenge that getting from finding of 11 countries. The first challenge is the inclusion of the list of rare disease in the national drug list or health benefit package. One of the reasons is also challenge that occur from high cost of medicine for rare disease, so it may not be included in the list. And another challenge is about sustainable of funding for rare diseases, especially the country that mobilize or is from donation of philanthropy. And the last challenge is about distribution and readiness of Center of Excellence for Rare Disease. In case that the benefit is already provided, but there is no health workforce, there is no infrastructure available, people still could not access to the service. And from our finding, we found that there are lack of data on rare disease health expenditure and financial burden that include volume or percentage of rare diseases expenditure as the current of health expenditure, catastrophic out-of-pocket expenditure on rare disease as of the current health expenditure. And last one is the unmet healthcare needs of people living with rare disease, and this need more investigation. Thank you very much. And over to you, Alana.
Amazing. Thank you so much, Aung Sumali. And I think we have 2 minutes to spare, which is great. So I might just take an opportunity here. I saw there was a question in the chat. So I'll see maybe if Claude or Aung Sumali, you might be able to answer. If not, we can also leave it for our panelists. But the question is about, and it's written in Spanish, so I have a little bit of a translation, but essentially it says in Argentina, specifically in the province of Santa Fe, the Public Employees Health Insurance Program, I haven't tried the original medications I was using for my treatment, and they switched me to generics. The health insurance program, under the control of the Ministry of Economy, with very little patient input. How could the difference in cost for these medications be financed? Just wondering if either of you might want to respond to that, or if we can discuss a little bit more later during the panel as well. But
yeah, I can say just a word. Thanks, Alana, for the translation and for raising the question. I actually intended to answer to this in the panel session exactly, but yeah, to basically just, and here I really put my, I would say, WHO hat part of the department that is really dealing with this. The favorite option is, of course, to include the most efficient treatment as part of the benefit package that is provided by whatever is the coverage system, if it's insurance or National Health Service, whatever is the model. So, of course, there can be some changes when the policy is efficiency and that you have to move to generic medication. Of course, if you choose then to yourself opt for the specialized treatment, then you will have to burden the delta of the costs. Yeah, that's the usual usual policy of pushing for efficiency and increasing the use of generics. Thanks.
Okay, perfect. That's really helpful. Thank you, Claude. So I think now we'll move on to the case studies. So I'm pleased to introduce three of our case study presenters. So first we'll have Finn Guo, who is the Director of Information Research at Illness Challenge Foundation based in China. And then we'll have Ainur Apkanova, a member of the Scientific Technical Council of the Ministry of Health in Kazakhstan. And then lastly, we'll have Salma Kalfi, who is the Project Manager on Long-Term Illness at the CNAM in France. So without further ado, I'll pass it over to you, Finn, for your presentation.
Okay, thank you so much, Alana. Hello, everyone. I'm Finn Guo. I'm from the Illness Challenge Foundation. So SCF is a nonprofit organization dedicated to supporting the persons living with rare diseases in China. Today, I will give you a brief introduction about the rare disease medical insurance policy and the practice in China. As a worldwide, the high-cost rare disease treatment are limited in accessibility. China as well. So the primary challenge for patients with the rare disease patients remains the financial risk protection. As you know, some rare disease orphan drugs are extremely expensive. In recent years, China has moved this issue from the policy merging to the national agenda. The key milestones includes two domains. The first one is the National Reimbursement Drug List, the NRDL, which has been annual updates since 2019. And the other one is a rare disease catalog. We don't have the official definition of the rare disease, but the catalog, I think, is quite similar with that. So with the additions in 2018 and 2023, that now is covered the 207 conditions. So the rare disease catalog is the foundation of the all rare disease policy making. Because of the economic development and the encouraged policies, so more and more the orphan drugs are marketed in China. So listed in the NRDL is the most significant method for their payment. So you can see these two charts. So the left one. So the annual cost is less than the $50,000. Can through the negotiation be included in the NRDL, then the patient can get reimbursement. But the right part, if the negotiation failed, so the patient and families must pay by themselves. And also some treatment and medication, the annual cost is more than the $50,000. The patient also must pay by themselves. Facing this circumstance and the local government and try to find some pilot reimbursement schemes and current practice primarily just focused on the very limited medication such as lisosomal, difficult to pronounce it. So LSDs therapies. In specific, these two charts can show the improvement and the limitation. So you can see the left one from the 2019 to 2024 is 126 rare disease drugs were included in the NRDL with an average and 65% price cut. So you can see this chart, the left one, and the blue one. The blue one is a market price and before the negotiation. So the green one is after the negotiation. So you can see the price is reduced a lot. And also the green one columns are the market price in the US. So you can see this is quite different in the treatment price in China and in the US. On the other hand, you can see the right table. The also have 31 rare diseases drugs for the 33 rare diseases and not be included in the NRDL. And also the 19 drugs are high cost. So the pattern is clear, I think. The higher the cost, the lower the coverage. And no matter the NRDL cover or not, the China explores a multi-layer payment mechanism. I think I think the multi-layers are easy to understand. That is combining the public insurance and also the commercial plans and philanthropy and also the patient contribution. So the circumstance, the crucial innovation, I think I want to mention about this layer is inclusive commercial health insurance. This products is a low premium and also pre-existing condition inclusive and the business insurance. So that is quite different with the traditional business health insurance. These products function as I think it's a quasi public good. So the bridge the high out-of-pocket gaps, but not all places and not all provinces have these products. Let's take a closer look to how the multi-layer system works, and also the it means for the financial security of the rare diseases patient. At the national level, you can see here, I just mentioned the listed in the NRDL, the inpatient can get about 70 to 80% reimbursement. But if the treatment is not listed on the NRDL, non-NRDL, so and not included in the local policy, the patient must pay by themselves and rely on the inclusive commercial health insurance and ICHI and also the charitable donation. But we know the parts of the province and the cities, they have they launched some policy and try to solve that problem. So here I give the 4 examples, and Zhejiang and Shandong and Foshan and Hebei. So the 2 different places. Zhejiang and Foshan as demonstrate advanced models. And Foshan, you can see here, imposed on no drug restrictions. So the core idea is to use a medical aid to prevent families from falling back into the poverty because of illness. So here they use for the medical aid. And also the Zhejiang has 2 major innovations. The first one is set up a rare disease fund by collecting the 2 Chinese yuan from each insurance participants. And the second one is cap the patient out-of-pocket expense at about $15,000. However, the Zhejiang province as a local policy is currently covered only 2 high cost. You can see here the drug covered, just 2 high cost orphan drugs. Now I will give you the case about the Gosser disease, the imigluceries, the medications named the imigluceries, how to cover this one. So you can see here the Zhejiang government launched the local reimbursement policy. So this the imigluceries is very expensive. In China, the market price at around 150,000 US dollars. So it's very expensive. So this local reimbursement policy can cover the 90%, so $900K, and the remaining amount just $15,000. And also the low-income eligible patient can get the medical aid. The medical aid is up to the 14,000 US dollars. So that patient, this patient can get the medication for free. But not all the patients are eligible, so they must. But they also can participate in the inclusive commercial health insurance. Can get around the $5,000 for the reimbursement, and also some low income patient, if they have the catastrophic health expenditure as more than the 50%, they also can apply for the medical aid from the Illness Challenge Foundation. So we give them the assistance program is up to the 7,000 US dollars. So after that, the patient just need to pay the $2,600. So through the coordinated financing, the patient out-of-pocket expense is reduced from the 150,000 US dollars to the $2,600, less than 2% of the total cost. Summarize the China core strategy for the financial protection of rare disease patient is a multi-layer system within framework. Different payers play distinct role. You can see here the government through the price negotiation and let the drug cost reduce, and also the market, the quasi public products like the ICHI and all offsets the high costs, and also the third sector fills the last mile gaps. Okay, I think the very important aspects I want to mention here is a paradigm shift. So from the cost effectiveness to social equity and the public good governance, and not just focused on the price of the medication. So we also have the four directions in the future. The first one is National Rare Disease Fund, and established that special fund for the rare disease, the persons with living with rare diseases. And also the second one is enhance the coordination from the different parties, like the public insurance and also commercial plans and the philanthropy, and also some other parties want to pay by the treatment. And the third one is pilot innovative payment models. So like the outcome-based insurance and managed insurance agreements like that. The last one, the version. So we want the persons living with a rare disease in China and can get the accessible care and affordable drugs and reliable coverage and inclusive support. Okay, let's stop here. And if you want to some more information or some discussion, please email me or connect with me on the social media. Thank you so much, Alana.
Wonderful. Thank you so much, Finn. That was a really great presentation. I don't see any questions coming in for you right now, but at the end of the case studies, we'll take a pause and see if anyone has any questions for Finn or for the other two case studies. So for now, I think I'll pass it over to Ainur for the presentation for Kazakhstan.
Hello, everyone. It is my honor to represent the case of Kazakhstan on behalf of Kazakhstan's Minister of Healthcare and other important stakeholders, specifically national fund called Kazakhstan Khalqna, which means to the people of Kazakhstan. And let me try to change the slide. So hopefully you see my next slide, which is the title page. I'm currently the member of Minister of Healthcare Scientific Technical Committee, although I'm currently outside of Kazakhstan. So my next slide shows the key picture of governance or the core stakeholders who ensure healthcare financing of rare diseases. So first of all, it's Minister of Healthcare and Minister of Labor and Social Protection, which jointly use central government budget. Specifically, Minister of Healthcare issues policies and procedures which guide the work of Social Health Insurance Fund. The Social Health Insurance Fund was launched nationally in 2020, recently, 5 years ago, and based on 2023 data, it covers 65% of all rare disease financing in the country. In addition, Minister of Labor oversees State Social Insurance Fund, which has just the generic scheme of social payment for disabled people. So in case a person with a rare disease is disabled, then they are part of that scheme. So there is no special disability for rare disease, but if rare disease is considered a disability, then as defined in generic terms, they get payments, fees, and they get equipment covered, purchased for medical supplies. That comes from the Ministry of Labor and Social Protection. In addition, Ministry of Healthcare oversees other national agencies. Because of lack of space, I didn't list all of them, but one key is called National Medicines Procurement Agency, SKF. They procure medicines overall for the entire country under public insurance pooling scheme, including rare disease medicines. And what has happened recently, a year ago, Ministry of Healthcare, with the help of another stakeholder, the fund, they opened a Republican Coordination Center for Rare Diseases, which is housed, the secretariat of it is housed in an independent hospital group. And they ensure the work of Ministry of Healthcare's committee on expert committee on rare diseases, which defines which diseases to include or medicines to include into positive lists covered. So I'm just trying to give you a picture of key players. So in addition to these entities, there is local governments, territorial, about 20 territorial bodies in the country. The local governments cover about 14% of entire national expenditure on rare diseases. This is as of 2023 data, and those percentages kind of change year to year, so it's not this fixed percentage every year. And they use local budgets to cover expenses not otherwise covered in general schemes in the general pooling system. So local governments may cover care costs, medicines, supplies. And a key player I would like to thank, who provided most of the information for my presentation today, Ms. Gulzia Bidatova, who works as a key person overseeing health policy at Kazakhstan Halkana Charity Fund. The charity fund is an independent body which collects donations from legal entities, from individuals, and it channels its funds mostly to healthcare, and within healthcare, including to rare diseases. So, and I'll explain further with more details on the role of each of these stakeholders, but I hope it gives you some understanding of the dynamics, that this is like a multi-layer, multi-stakeholder process in Kazakhstan. So this slide shows some key facts as of 2023, and I thank Minister of Health, Akhmaral Al-Nazarova, who shared the information with me. So as I showed in the previous slide, still the government, the primary pools through social health insurance funds covers the majority of expenditures, 65%, and then the private donations cover 21%, and local governments, which is public funds as well, another 14%. And so in the Ministry of Healthcare issues regulations, and currently it's about 66 specific diseases covered or paid by government under these public schemes, which include 194 medicines under MOH list. But in fact, Kazakhstan procures more than 200, which includes private funding as well. And at 3 levels, rare diseases are supported: primary care. They distribute covered medicines. So free medicines are distributed for free to patients, which are procured centrally and distributed through the network of primary care providers. And they provide constant disease monitoring and care. And their primary care is financed generically as per capita financing, but medicines are procured separately and distributed through primary care networks. And then secondary tertiary care hospitals, they provide inpatient care when needed to patients with rare diseases, and they're reimbursed generically through DRGs, which are established in the country as a fee-for-service mechanism. So the role of Ministry of Healthcare, I have included hyperlinks. So if readers can get a copy of these presentations, they could actually click and see the actual policy with a positive list, like the list of specifically covered diagnoses, which Kazakhstan defines as a rare disease in this country, or medicines specifically related to each diagnosis. And also there is another order on the review process of the positive list. It's reviewed at least annually or more often as needed as information comes in. And then another important order is on how to import unregistered medicines, which applies to rare diseases usually. And also Ministry of Healthcare defines policies. There is a roadmap on improving care for orphan. In the Russian language or Kazakh language, we use, instead of term rare diseases, the terminology is usually orphan diseases. And then the expert committee, which is chaired by the Vice Minister of Healthcare, they decide on the justification information for medicines that should be included in treatment of rare diseases under publicly covered schemes. They also guide coordination of care for patients. So they basically approve protocols for care coordination, and they also assess outcomes of treatment for future cost effectiveness decisions. And what I wanted to explain is there is this new stakeholder, which was just created 3 years ago in 2022 by the order of the president of country, when we had a big, like a natural disaster, flooding. To help people who suffered from flooding, they established this charitable fund. So this is not specifically for healthcare. So one reason to create was natural disasters. But interestingly, if you look at their expenditure, their official reports are published publicly. The link is provided on the slide. So the latest report was 24 report. They showed 51% of their funding went to healthcare projects. And then all the other sectors, education, social support, disaster relief, sports, culture, took kind of less than half, I mean, the other half. And so they implement charitable projects in partnership with other stakeholders. They work with local governments, with national actors, and so they play a key role currently in Kazakhstan in funding rare diseases that are otherwise not covered by the Ministry of Healthcare's Social Health Insurance Fund and the Guaranteed Benefits Package. They also act as an agency that promotes the culture of philanthropy, and I explain later why it is very important in context of post-Soviet countries in Kazakhstan, for example. So it's basically like a mechanism for voluntary distribution of wealth to support social needs. And they have this report on their annual income. So it's not a stable income, but you know, it is better to have something than nothing. So this is the vehicle where individuals or companies donate their funds as part of their social responsibility, corporate social responsibility projects. And so this slide shows how financing is done by this fund for rare diseases. So from that annual report for 2024, they have signed 74 contracts, for example, to procure expensive medicines for rare disease patients. They have covered, you know, a specific number of patients, like 208, of which 138 were children. They have purchased 20 unique types of medicines. And one of them was introduced for the first time in the country. And so they have allocated this much money in 2024 for rare disease medicines, which is equivalent to $62 million US. And in addition, this body, the Foundation Kazakhstan Halkına, which the name of Kazakhstan Halkına means to the people of Kazakhstan, they have advised the Ministry of Health to create a national coordination center for rare diseases, which has happened. So Minister of Health has supported. So Minister Akhmaral Nazarova last year has officially opened this new body. It's housed at the University Medical Center private hospital group. And it was symbolically opened on June 1st, what we celebrate in Kazakhstan as the Children's Day, International Children's Day, because rare diseases, I think there are more pediatric patients than adult patients in Kazakhstan with rare diseases. So that was symbolic. And according to what I found out is CIS Rare Disease Consortium, Orphan Disease Consortium. This is the first agency in the CIS space that specializes on rare diseases. And this body, the Republican Coordination Center, it's like a methodological center, like a health policy center. It provides quarterly reports to Ministry of Healthcare. But it wasn't just created last year. In fact, for more than 15 years, this work was done. It was just not officially called as an agency. It was done by a committee. There was a working group. So I would say it was a natural progression in development. And so to speak more about this role of this Republican Center for Rare Diseases, they help to coordinate care for patients. They literally guide patients who have suspected rare disease to confirm their diagnosis, to guide them where they should go for specialized treatment. They basically work with patients to provide them psychological and social support, try to help to navigate through all these stakeholders. and they keep the registry of rare disease patients. So they help to account, like to create basically the statistics on rare diseases in the country. They work with patient organization. They also organize education and outreach for clinicians, especially what we call them clinicians in the regions, like faraway cities or even rural areas where clinicians may not know enough or much about rare diseases, how to correctly identify a channel and refer these patients up the channel vertically. But the most important role, I think, is number 3 here, methodological support of coverage decisions for MOH. And so I would say that they are the ones who guide policy for Ministry of Healthcare. Basically, Ministry of Healthcare has outsourced that work to this body. And they also help to guide centralized purchase of medicines. So the actual purchase happens with the medicines agency, but they do all the paperwork. They sift through packets that were submitted, and then they basically are the gatekeepers of funds, national funds. Next slide shows a work that has been posted online publicly by this Republican Center for Rare Diseases. So this they have 3 workflow charts. One of them is here. It guides patients who have a potential rare disease, which like navigates them how to get their diagnosis confirmation. So diagnosis confirmation process goes as this. So such patients are identified from all parts of Kazakhstan, and Kazakhstan is a large country, 9th largest in the world, but very sparsely populated. Only 20 million people for 9th country in the world means like we have faraway places which are very distant from specialized hospitals. So geographic access is an issue, and this helps to basically make sure that no one's left behind, that regardless of their residence, people can be channeled, referred to specialized centers nationally. And then they are observed at primary care level, but if needed, they go through molecular genetic testing and confirm their diagnosis, and then they become, if confirmed, part of the registry. And this interesting chart is also from them. It helps to guide this entire procurement system. And I think this is interesting because it's like a tiered level. So if medicine for rare disease is already part of the approved positive list of the Ministry of Healthcare, then it's procured by the Ministry of Healthcare's Agency for Medicines. So on the top right, on the right side of the slide. And then next, if it's not covered in the positive list, then Kazakhstan Khalkhna Foundation, the charity fund, kicks in its mechanism, but it has to have evidence, like scientific evidence on effectiveness and such. But if none of that works out, if, for example, a certain treatment doesn't have enough evidence on efficacy and all that, but patients have strong advocacy and they still want to be covered, then they're referred to local governments. And a protocol decision, the committee meeting decision says there is no scientific evidence to support the purchase of this medicine at the national level using public funds, but you, local government, if you have money, you can do it. So local governments then deal with their residents specifically for new treatments or maybe old treatments that lack medicines per decision of the national committees. And then if the medicine is not even registered in the country, then a notice is sent by this Republican Center for Rare Diseases to Ministry of Healthcare to either ensure and organize a one-time import of unregistered medicine, or through a regular mechanism, health technology assessment is done, registration is done, and maybe it's considered to inclusion into the positive list of the Ministry of Healthcare. And what is interesting, this Republican Center for Rare Diseases ensures continuous patient condition monitoring, because the cost effectiveness was a big issue for policymakers. They spent a lot of money on these rare diseases, and then what's the outcome? So every 3 months, they receive feedback from patients, patient families on how they're doing. And if a death is registered, they also mark it. So the importance of long-term continuous monitoring is to inform future purchase decisions. They classify cases as positive response to therapy or no response to therapy. So I think that is kind of a new initiative on kind of cost effectiveness, accountability amid ethics. It's a complex function to perform, but we have now a body that's dedicated to this function. And what I've learned is there is this CIS Orphan Consortium. Its secretariat is located in Moscow, Russia, but they basically have information on former Soviet countries. So CIS stands for Commonwealth of Independent States, which is a union of post-Soviet countries, not all of them, but some of them. And so on that, I just took it. I was interested to see that there's such a body, in a regional body, that collects evidence on which country does what in this area. So this is just for information. And this is my last slide. So there are challenges in the country. The biggest challenge in the healthcare right now is diminishing fiscal space. So despite the introduction of social health insurance reform in 2020 and temporary increase of healthcare financing since the launch of health insurance reform, because since 2020, employees started contributing in addition to the previously existing allocation of budgets from central and local governments. Over time, with inflation and with growing burden of diseases on healthcare system, overall, that additional money's effect was not felt for long. And not only that, in addition, Minister of Finance, which allocates funds to Minister of Health and other ministries, is experiencing in the last several years a shortfall in revenues from taxes from other sources. And in addition, the factor is inflation in Central Asia is as well suffering from very fast inflation rates, and that all affects the healthcare in a way that Social Health Insurance Fund is experiencing delays in receiving promised allocated funds from the Minister of Finance. So Minister of Finance is not fulfilling its duties of timely transfers of government budget to Social Health Insurance Fund. As a result, Social Health Insurance Fund is delaying its reimbursements to healthcare providers for provided care. And so then hospitals experience lack of income, lack of revenue for promised provided services. And that overall situation, of course, affects financing of rare diseases. And so although I showed you data from 2023, in 2024, both the percentage and also the financial amount of money spent from central government from the pooled social health insurance fund has decreased in 2024 compared to 2023, which is a sad fact, but that's the result of this overall larger factors. Also, specific domestic situation is there is this tension between Ministry of Healthcare and the charity fund, Kazakhstan Halkına, because as described by policymakers as lack of joint vision for strategy in financing rare diseases in the long term. So there's this constant pushback, like who should fund this? You know, Ministry of Healthcare tries to convince the charity fund to pick up more of the rare diseases, while charity fund believes it's the pooling is best under Minister of Healthcare's Social Health Insurance Fund umbrella, but that dialogue is always heated. And also another fact is about 80% of patients in Kazakhstan with rare diseases, in fact, are pediatric palliative patients. So the question that arises in policy rooms is, do these palliative patients really need futile, super expensive care? Can we just set up high quality palliative care, which is not even a guaranteed thing? So now policymakers are working together to create basic but reliable, equitable access to palliative care across the country. So that's another point for food for thought. Another challenge is outcomes monitoring. So now with this body, a Republican Center for Rare Diseases that monitors effectiveness of treatment, it is now a question or like a tension between patient advocacy, patients have stronger and stronger voice each year, and then versus like true evidence. And what is seen by policymakers is that pharmaceutical companies act as predators who just basically hijack patients on their emotions and provide patients with the flame and passion to advocate for patients' case. But in fact, it's driven by pharmaceutical companies' interests because unfortunately in Kazakhstan, there's no strong base for price negotiations. The population is very small. So typically whatever price is quoted is reimbursed for these patients. And so it is interesting to that the government itself sees kind of pharmaceutical industry's shadow in the eyes, while it's the vehicle for them is patients or patient advocacy groups. And another local context issue, typically in post-Soviet countries, policymakers can't say no to patients. It is the post-Soviet local mentality where patients believe government must cover it, whatever it takes. In Russian language, we call it like a dependency syndrome, but that is something local in specific, and that's why it's important that the Kazakhstan is evolving by introducing agents like charity foundations, where private donations are applauded or supported, because the idea that not just government should cover everything and for everyone, but that private efforts can also matter is kind of new in this post-Soviet space. So it's interesting to involve additional players, which are sometimes private players in this case, such as the charity fund. So so that's overall context, and I finish here if you have any questions for me.
Wonderful. Thank you so much, Ainur. I don't see any questions now in the chat or in the Q&A, but please, if people have any questions for any of the speakers, please do send them in the chat in the Q&A. I saw you got some reactions, Ainur, some clapping emojis. So I will now pass it over to Salma for the case study on France.
Thank you very much. I hope you can hear me well and you can see my slides. Perfect. So hello, everyone. I'm Salma Kalfi. I work at the National Fund for Health Insurance, Assurance Maladie in France, which is the National Institute for Social Health Insurance. And I'm very happy to be here today and to share with you some key insights on rare diseases coverage in France. To start with, rare diseases represent an important public health concern in France since the late 90s, when the topic caught the attention of public authorities. There are 3 million people affected by rare diseases in France, which represents 4.5% of the population, and 30 million in Europe. And in France, half of the people affected are children under 5. And these rare diseases are responsible for 10% of deaths among children between the age of 1 and 5. We can say that France is a pioneer in the field of rare diseases at the European level, as the first country in Europe to have developed and implemented a national plan for rare diseases. And this brings us to the achievements. The achievements that France has accomplished with the experience and evolution that it gained in the last 20 to 25 years. If we can say on the institutional framework side, we have since 2001 a rare diseases platform that brings together the main non-governmental players in the field on a single website, including Alliance for Rare Diseases Info Services, which is the info service that can be contacted by patients or patient family members for any type of questions. We have also Orphanet in this platform, and Orphanet is a unique initiative that gathers and disseminates knowledge to improve detection and treatment on rare diseases. That was created in 1997 by the National Institute for Health and Medical Research in CERM. And this initiative quickly became a European effort in the 2000s, funded by European Commission contracts. Orphanet gradually transformed into a consortium of 40 countries now across Europe and around the world. It's really a kind of dictionary for rare diseases where we can find quite a lot of information in the same place. On the structural side, there was a succession of 4 national plans for rare diseases since 2004, led by the French Ministry of Health. And this has resulted, among other actions, in a structured framework with multi-layers, as we have seen just now with China and Kazakhstan. And there are 23 healthcare networks which act as a kind of umbrella, coordinating all the different actors involved in rare diseases. including reference centers, competence centers, universities, research institutions, and so on. So we have 122 coordinating rare disease centers composed of 603 centers of reference. And so each coordinating reference center manages a network of reference centers. And these reference centers are ensuring a multidimensional coverage on the regional, national, and sometimes international or European levels. And at a more local level, the healthcare networks rely on more than 1,700 competence centers in rare diseases. And these are centers of expertise providing care and follow-up to patients. And both the reference centers at the national level and the expertise or competence centers at the local level have specialized medical teams with expertise in a specific rare disease or in a group of rare diseases, and also do training and research activities, among others. And here I just wanted to highlight the importance of institutional structuring through a 20-year progress. Each national plan brought progress, and France got more efficient in time to reach this ability to match each patient with a specific expert in his rare disease, thanks to these health networks and reference and competence centers. And last but not least here, the national plans also led to the creation of a national rare disease data bank. And this database aims to establish a secure structure for collecting anonymized medical patient data, which is collected directly in the rare diseases reference centers and competence centers. And sorry. Okay. Going on financing mechanisms, the coverage of rare diseases by national health insurance depends on the rare disease. It can be taken in charge fully by social health insurance in the case of chronic and very costly rare diseases and their long-term illness scheme. And for the other rare diseases, they are taken in charge at standard coverage rates as any other disease. And the remaining fees are taken in charge depending on patients' subscriptions to private insurances. There are other social benefits, as mentioned previously at the start of the presentation, and assistance that is provided to rare diseases patients that can be obtained in departmental centers and also at the Family Allowance Fund, CAF. And concerning public financing, the fourth national plan for rare diseases dedicates 223 million euros per year in funding to improve diagnosis, treatment, and access to care for the next 5 years. One of its objectives was to extend the newborn screening from 13 screened diseases to 16, which was reached. So there is a newborn screening program to all newborns in the country that is fully financed by national health insurance. In regards to orphan drugs, the treatments benefit from a regulatory framework at the European level. There is a centralized designation of these drugs as orphan drugs based on specific criteria, and only then they can be subject to a marketing authorization procedure delivered by the European Commission. In France, these drugs must be reviewed by the Transparency Commission of the High Authority of Health to be validated so that they can be registered and reimbursed by Social Security and made available to the market. All right. Moving on to the challenges. Diagnosing rare diseases and finding the right treatment once diagnosed remains an ongoing challenge for many patients around the world, and so in France, hence the importance of R&D. And the current national plan for rare diseases in France focuses on facilitating and accelerating diagnosis with measures such as strengthening diagnosis observatories, promoting the integration of new diagnosis methods, particularly in genetics, and also it highlights the importance of promoting access to treatment through structuring therapeutic research, encouraging the repositioning of existing drugs, organizing real-world data collection to better evaluate treatment effectiveness. And as an effort to enhance research on rare diseases, France joined the European Rare Diseases Research Alliance that was launched in 2024, which is an alliance aiming at advancing research into prevention, diagnosis, and treatment, and that is led also by the French organization INSERM, the National Institute of Health and Medical Research. In regards to data, it is crucial to know how to benefit from patients' available data to improve diagnosis and treatment. Although France has made progress in this area and actually led important initiatives as leader and coordinator at the European level, there is still work to do. The current national plan for rare diseases includes measures as to strengthen biobanks, to optimize information systems, and to develop AI to enhance data utilization. It also focuses on reinforcing European bridges in terms of data sharing and utilization. And here I just wanted to mention another interesting initiative and a European approach that is currently being deployed to enhance data sharing and utilization called Jardin Joint Action, launched in February 2024, that aims to boost health data exchange among rare diseases centers. And just to conclude, I would say that the French case remains a very specific one in Europe and abroad, given the specific French social model. France has the lowest out-of-pocket in the world at 7.5%, with a large coverage by national health insurance. And despite these large developments in coverage, structural organization, efforts are deployed and dedicated to rare diseases information systems databases and to research and program extensions as ways to accelerate these developments. Thank you very much.
Wonderful. Thank you so much, Salma. That was great. In the interest of time, I think we will move on to the panel discussion, but there are a few questions that have come in the chat. So I'd invite any of our speakers to take a look, and if you have any perspectives from your country or from the global perspective, it'd be nice to respond as well. I know there's one in the Q&A session or the Q&A section about cost effectiveness evidence. So if anyone wants to respond to that in writing in the Q&A section, that's great. And also, I love all the engagement in the chat. It's really great. So if anyone wants to ask any more questions, and we can also, of course, have more of a discussion after our panel. So I will now pass it over to Alexandra for the panel discussion.
Thank you, Alana. Thank you to all our presenters. There have been quite a lot of insightful information and data. I know it can be sometimes complex for non-economic people like me, but I'm sure it will help to inform, and this panel is going to dive into those topics. So we will have now a discussion, and I'm honored actually to be joined by our distinguished panelists. So we have Professor Susan Horton from the University of Waterloo. We have Professor Lou Garrison, which is in the Comparative Health Outcome Policy and Economic called Choice from the Institute and Department of Pharmacy at the University of Washington and the Office of Health Economics. We have also Dr. Joseph Babi Gumira from GHE Consulting and is MD trained health economist. And not last, Monsieur Claude Meyer from World Health Organization and P4H. So thank you all for being here. The panel discussion will explore three main questions. The first question, it's about how can we bridge systematic gaps in rare disease care? I mean, we've seen from the presentation and from the cases that there are some gaps, but there are also some innovative pathways. So indeed, rare disease are often highlight deep-rooted inequities in health system, particularly around financing and access to lifelong care. So drawing from the findings, notably presented by Aung San Mali and our country case study, the main question here is how can country design a sustainable and equitable health financing model that integrate rare diseases as a core component of universal health coverage? So this is the first question for our panelists. And I will invite Joseph actually first to give his perspective about that question. Thank you, Joseph.
Thank you very much, Alexandra. It's wonderful to be able to join this panel. And it was wonderful to hear all the results from the different countries. I'll focus on priority setting frameworks, structural barriers in low-income countries, which I kind of represent, given that I'm from Uganda and I'm in Uganda, and also talk about equity. So as you know, the results showed in Tanzania and in Cote d'Ivoire, there's really no rare disease financing. And trying to build specialized coverage on broken foundations is not going to basically work. So because of that zero rare disease coverage, essentially they rely entirely on out-of-pocket payments. Three things have to kind of happen to sort of move things forward. One is that poor countries need explicit priority setting networks or frameworks, sorry. And the challenge isn't whether to cover rare diseases, but how to prioritize systematically. So there has to be a balance between disease burden, cost effectiveness, and thresholds to be able to, you know, sort of bring financial risk protection and equity considerations into practical application. The other thing is that there's a need to address structural barriers because of fragmented financing systems and a very tight fiscal situation. So I heard from, you know, some of the more, you know, Central European countries and even China about limited fiscal space, but in countries in Africa, that space is even more limited. So countries like Tanzania need to strengthen core financing functions before they can even attempt coverage for rare diseases. And finally, the equity has to be built into the systems because you can't sort of have equity retrofitted. It has to be a design principle. So progressive financing has to go through general taxation. And I like the example of India in the results, which is essentially explicit poor targeting. So I'll pause there for now.
Thank you very much, Joseph, for giving that perspective from a low-income setting country. I would like now to turn to the next panelist, which is Lou, to give his perspective. Is it all okay for Lou on the technical side? Because we do not see him.
Yeah, Alexandra, can you hear me?
Yes.
Okay, I'm sorry. I don't know what, I lost my camera or somehow from the beginning, but maybe that's better for the audience. They don't have to see me. That's all right. Yeah. So anyway, really, thanks so much to RDI and P4H for this invitation to this important discussion. I'm a health economist. I've been doing health economics for decades, and I've done global health work. I was in Kazakhstan last year and China this year. So I've gotten around. My principal home is ISPOR, which is a health economics and outcomes research organization with 20,000 members. There I head up a special interest group on global access to medical innovation. So this medical innovation is a global public good in a technical sense, that the knowledge can be shared around the world without using it up. It doesn't mean everybody gets it, but in principle, they could. So, well, but we do observe tremendous lags, and I'm going to speak mostly about pharmaceuticals, but obviously, as Joseph was mentioning, you need diagnostics, you need system readiness, you need all the other components to provide access to these rare diseases. But I've been doing work in recent years on cell and gene therapies and how do we justify the price, even in the US, of a high-cost therapy. But I kind of start with, though, we already have kind of a drug lag, as we call it, from first launch globally, and 65% of the medicines launched first in the US. And I'm looking at a recent paper that it's 8 years before they are launched in low-income countries, and that's for essential medicines. so it's not just rare disease medicines. And I would like to see, so in some ways it's a little surprising to see so much activity in all of these countries around rare diseases. But I think it speaks to the kind of social equity aspect of the way populations view this, that we, I always think of the Chilean miners, great effort to rescue the Chilean miners or the Thai boys in the cave. So for rare catastrophic events, societies are willing to pay more. And we know that, with 8 billion people on Earth, where, the RDI statistics are about 300 million, might suffer from rare diseases. But basically, if you look at it, at birth, you have about a 5% chance of having a rare disease, or your children do, or your grandchildren do. And so that creates a lot of uncertainty in your mind. And so in our field, we've certainly emphasized financial risk protection, but that's what we call health risk protection. That I'm at risk, a 5% chance at birth of having a genetic disease. So over, how much would I be willing to pay over the rest of my life to either cover a cost of that or to contribute to the R&D for that? And we've got to remember, and again, it's not all just pharmaceuticals, but they are a driver, especially in recent years. About half the 50 drugs approved every year are for orphan drugs. We spend 300 billion to 600 billion in R&D. So that means it's costing billions for each of those new entities. And yet the marginal cost of making them, once we've invented them, can often be quite low. Now, that's less true with cell and gene therapies than with small molecules. But even in the small molecule space, we had challenges in getting HIV therapy to South Africa. Even at $125 a year, it could not be afforded. At the same time, we see that differential pricing can work. In the case of the Hep C drugs, between 2015 and 2019, 1 million Americans got those drugs, but 8 million people outside the US got those drugs because of differential pricing. So I think we need to think about, we need to do differential pricing. I'm sure the access lag is here, but I think one of the lessons here from what we see is there are important social equity and altruism motives here. We do care about strangers, we do care about these risks. And so these countries are all using creative schemes to sort of supplement universal health coverage. So I think we would all like universal health coverage, but this is kind of a special case. And I think there's also, I'm sure as Claude will remind us, it's not just the medicine or the medical care, it's the disability and the income and the effect on the whole family that you kind of need to insure from a social insurance point of view. So anyway, I think we just got to understand that it's great to see this happening, and there's a real equity component within country and across countries that we need to consider.
Thank you very much, Lou, for this perspective and in phasing around health risk protection. Indeed, we have to remind that 70% of rare disease are genetic. And strengths, emphasis also on equity. Now I would like to turn to Sue Horton, which has also a great experience having co-chaired the Lancet Commission on diagnosis, which was a lot about equity as well. So please, Sue, if you can give your view on the first question, which is about bridging systematic gaps in rare disease care.
Yes, I'm going to give two main points. Firstly, I'm going to talk about inequities between small and large countries and how to bridge that. And then secondly, I'm going to say you have to walk before you run. You have to start slow and then build up. So on small versus large countries, if we look at newborn screening, small countries typically do not have such systems because it takes economies of scale to put together the infrastructure and the regulations to do this and to put together the labs. So the Caribbean countries, I am surprised, don't have newborn screening. They don't have labs, yet they are high income, middle and upper middle income countries. So smaller countries need to collaborate and pool their resources and build centers of excellence that can serve a region. And we see already Africa leading the way on this. Many small countries, but the African Medicines Authority is doing its best to produce medicines within Africa at affordable prices. So I think regional collaboration is going to be the key for small countries, otherwise they will be left behind. And secondly, the start slow and then build. I think if you look at the history of how support for rare diseases came in the high-income countries, it was started about 50 years ago with two key diseases, congenital hypothyroidism and phenylketonuria. Okay, and these were diseases that had catastrophic effects on the children who were born with these conditions, in that their entire life was harmed by the cognitive defects that they suffered. And yet, the treatment in terms of appropriate diet was not wildly expensive. So I think countries have to choose the most tackleable diseases in their region. Even for the low-income countries, it's possible to do that. In sub-Saharan Africa, there is currently an initiative across the continent to tackle sickle cell anemia, which is more common in Africa and also potentially tackleable, and yet has devastating effects. So I think countries have to pick carefully where it's possible to start, and then they will build a community, because the success in that community will help others bring everyone together and realize, yes, these things can be tackled, even though they may be expensive. So thank you, Alexandra.
Thank you very much, Sue, for this very pragmatic approach, how to address the challenge of care for rare disease in middle-income countries. Now I would like to ask Claude to give his perspective, and I think he must have a very interesting one, being so involved in social health protection. Thank you, Claude.
Yeah, thanks a lot. First of all, I hope that my camera and my computer will not crash, because this happened already twice in the last 10 minutes. Let's pray for this not to happen. Number one, and it's really about the question about equity. We can share so many stories in WHO of different specific disease groups that start to make investment cases, specifically investment cases, and where basically the issue or the objective is to calculate what would be the cost to cover this specific area of diseases. And that's not specific to rare disease. And we end up at the end of the journey with a proposal to set up a specific fund in a specific country. This is not the route to take from our point of view in the Department of System Performance, Financing and Delivery. This is a wrong route, and then if you use that route, you might end up, of course, with path dependency and trying to solve this problem afterwards. So number one, really recommendation is to try not to set up a specific fund that will pay for the health expenditures of rare disease. Of course, it can be in terms of revenue raising. If you want to be creative and find new sources of funding through donations, or this is all fine, but please really do not set up a separate fund to purchase the health services for people living with rare disease. That's number one. And in a way, and this is really related to equity in the sense of equity means spreading the risk across the biggest number of people. So in a country, it's the whole population. So basically to spread the risk with all the people that are not living with rare disease. And there I have seen in the chat a question where somebody, I think it's Graham, who is proposing to have a model with high-income countries paying a small levy to create a central, and in that case, I think a global fund that could be accessed by low-income countries. From a purely equitable point of view, this is absolutely correct. You cannot be more equitable than having a management at a global level and basically for the whole planet of this problem. The only comment I have is that this is not very trendy in our current world, and a world in which many stakeholders are talking about closing the global fund for AIDS, malaria and TB. and sunsetting Gavi. So yes, from an equity point of view, this is absolutely correct. From a feasibility point of view, I have great doubts. Thank you.
Thank you very much, Claude. I'm actually quite pleased to have the notion of a global fund that came here already at that stage of the discussion, because this is something indeed that some of member states have talked through. It's in a very early discussion. The context indeed is probably not the most appropriate right now, but again, if we find innovative solution that can create sustainable funding, perhaps there is a way here. So, but this is for another topic at another time. So to go back to our panel discussion, the second question we wanted to ask you, it's really about looking at some unlocking innovation for sustainable access. So we have heard from the different cases and from the study as well that there are some innovative financing system and some design approaches such as National Rare Disease Fund, regional risk pooling, outcome-based payment, and differential pricing. All of you already have touched on this in your first question, but if we want to dive a little bit more on those solutions, what is, according to you, those innovations that hold the most promise for improving access to rare disease treatment without and care, without compromising financial sustainability, particularly at the moment? And especially in low and middle income countries. So for example, what enabling conditions are needed for this model to succeed? And then how can social health protection system be integrated to support both health and non-health needs? So again, very challenging question, but I'm sure that you'll be able to provide some element of reply. So I will start with Lou this time. If you can elaborate a bit more on those questions. You turned off, you muted.
Thank you, Alexandra. I'm sorry I couldn't get my camera on.
And we're happy to see you now.
I did get it on. I tried. Okay, I can't see that. Okay, good. I didn't see it was on. So, yeah, I mean, okay. So basically, I believe in global differential pricing. These are global public goods. They should be, rich people should contribute more than poor people within country and across countries. So how do we make that happen? The answer is it doesn't happen very well now. We spend about as I said, 300 billion to 600 billion a year. We invent 50 medicines, half of them are orphan drugs. The US finances 50 to 60% of that. Increasingly, China is producing almost as many medicines as the US. So the world is moving in a good direction from that standpoint. But I basically think we need to try differential pricing, and I would emphasize that that this whole idea of health risk protection means that we are willing to pay more in rare catastrophic situations than we would in other situations. But when you think about the production of medicines over time, you would expect that there would be diminishing returns. It gets harder and harder to come up with new medicines that produce health. And if things get more difficult, that means you have more failed trials. But in order to get the science to advance, so it costs more. So we expect that the cost of these innovations is rising over time, but yet they can benefit 8 billion people on Earth. So we got to find a way for everybody to contribute according to their ability. But I mean, we need to differentiate between the R&D cost and the marginal cost of making it and distributing it. Now, if you're very poor, if you can't cover the cost of goods, the marginal cost, then we're going to have to subsidize, which is what happened with PEPFAR, which has unfortunately been removed, right? But that's what happened, and that was an example of kind of a recognition of some social dealing with social inequities global. So I guess I think I want to start with differential pricing. I think Claude is right. We got to be very careful about disease-specific funds, because it distorts. Ideally, we would have things in a universal health package that we do value-based assessment. And again, I would say the value of the value is very high in these conditions, which is why we pay a lot. And it's also not just because for the 5% of people who are going to have a genetic disease, it's because it's for the 95% of people who are at risk, and they live in the uncertainty that they may get it. So they're willing to finance the development of these medicines. So I think we have to look at it that way, but we haven't come up with a good way. I do turn to the NRDL in China. I like the rapid that it's speeded up. I first went to China in 2009 to talk to the Central Drug Committee. And since then, they've instituted this rapid health technology assessment where they do a value-based assessment and negotiate a price, and they do it rapidly. So I would encourage individual countries to take that approach of HTA that's rapid and efficient.
Thank you very much, Lou. I would like to ask Claude. Where I am? I'm lost. See, no, sorry, I mixed my intervenant. I'm sorry about that. Sue, please, over to you.
So I would very much agree with Lou that differential pricing or tiered pricing is one of the important ways to go. We know that this was successfully done for antiretrovirals. It helped that there was what's called pooled procurement by the Global Fund, that they could negotiate with the often monopolistic producers and be a monopsonist, a large buyer, and force prices down. And similarly, China has done the same thing as a huge purchaser for drugs. I read an article about Nusinersen that they've managed to get a much lower price. And I think Gavi, the vaccines initiative, tells us that we are willing to have the lowest prices for the poorest countries, and that as they graduate and become more able to afford it, then they can pay higher prices. So I think the tiered pricing, pooled procurement is very important. The other side of it is also the supply side. At the moment, we're giving huge patent protection to the orphan drugs producers, and it's been very successful in that we get many more of these drugs produced, but it's been unsuccessful in that the prices of these drugs have remained high. And even after the patents expire, they try to hold on to their position in the market. Okay, and we have to deal with that. But unfortunately, one of the ways to deal with it is for the low and middle income countries to actually produce these drugs at lower costs and at lower prices than the high income countries. So that's been a difficult sell. This is something the low and middle income countries constantly want to ask in the World Trade Organization that they should be allowed to work the patent once the patent expires to produce the items locally. And Africa, again, is making incentives in this area. They have set up the lab in Senegal, which I can't remember, it's producing vaccines at lower prices. And more of this has to occur. I mean, it's not fair for the orphan drug manufacturers to continue receiving high rewards and meanwhile depriving people of the ability to purchase these things. Thank you.
Thank you very much, Sue. And now I would like to ask Claude actually to feed into this discussion.
Yeah, thanks. I actually would like to, on the innovation part, I would like to just give one example that is perhaps also very much in line with the differentiated pricing, etc. There is one area that the department in which I sit has neglected a bit in the past, and that is working more currently. It's the connection between the financial incentives and the service delivery design system. So basically, when you have a certain type of service delivery, and particularly in the case of prevention, detection, etc., and you couple this with financial incentives from those different payers, I think this is a kind of promising avenue that has not been sufficiently explored. Another comment, and that is more about, I would say, the second part of the question, that is the non-health type of needs of the people living with rare disease. It's true that very often health systems people, and this is very much core to our mission in P4H, where we try to connect different sectors, the sector of social protection, of health, of public finance. Very often health system, I would say, experts tend to forget that the needs of a person living with rare disease are complex and are diverse. You have, of course, the health expenditure needs, but you also have needs in terms of transportation, in terms of social care, in terms of housing, and of course, to factor all those different needs into the situation of one specific person and to organize a social protection system around this is also, I would say, something that is very often forgotten. Thank you.
Thank you very much, Claude, for bringing this. And actually, if I can give just one personal view as a moderator, but I think the example of Kazakhstan was particularly informative about this coordination of the different aspects actually that touch a person living with rare diseases. And this is part of the conclusion that I think I would emphasize is about the importance of coordination between different sectors. So thank you for bringing this. I'm aware about the timing, and I will still like to ask Joseph his perspective about those solutions that we have seen, we have heard, and what is the most meaningful for you, for example, in a country like Uganda.
So very quickly, I agree with everything that was said about differential pricing and how that might work. And I'll touch on dedicated funds, like the more local country funds, like the one in Russia and the one in Kazakhstan. But of course, they cause donor dependence. And we've seen a good example of donor dependence play out with the dissemination of USAID. So right now in poor countries, there's a really bad taste about donors and donor dependence. Essentially, where we expected that people would be making a case for the money to come back, I've seen in circles in poor countries, people saying we just don't want this anymore. So there's both a loss of the resources, but also a really sour taste in people's mouths because these, these donor funds and these dedicated funds cause donor dependence. So there's a need for more local solutions. And that's something that the rare disease space might consider. Instead of trying to create these, global funds, what can happen locally, because we are the whims of the donors. So if one president stands up and disseminates one big fund, then we're back to zero. The second one is that I would like to touch on is pool procurement. I think pool procurement, like Sue said about the monopsonist position, governments can pull together, maybe like ECOWAS, so the Eastern African Community. Because for a drug like hydroxyurea for sickle cell, the amount of money needed to treat hundreds of thousands of Africans is the same amount of money needed to treat a few hundred or so with a really innovative new drug. And if you have a monopsonist player like the East African Community or ECOWAS, then that that can move a long way.
Thank you very much for bringing the importance of local law solution, which is also linked with what Sue was saying, with the importance of having the facility to produce some medicines for local country. We end this second question. We have a last question, but we would like to give some time to question and answers because we have some. So I'm going to ask you the last question to you all, but I'm going to ask you to reply in perhaps 2 sentences maximum. As you remember in my opening remark, I mentioned the fact that the World Health Assembly has adopted a resolution on rare diseases in May this year. And this resolution is asking the World Health Organization to develop a global action plan on rare diseases. We expect that global action plan should be developed in consultation with all the different stakeholders. And we're waiting for the clarity on the process about this, and I'm very confident it will come. But in the meantime, the community is preparing an RDI with its members and partners like P4H. We are looking at then some solution that could inform the global action plan on rare diseases. So based on what we have heard today and on your reflection that you just brought, what would be the main recommendation if you had to give one to the member states that are going to have to develop that global action plan and adopt that global action plan in 2028? I would like to start by Claude.
Okay, thanks a lot, Alexandra. Sentence one, we would need data about financial protection, or basically financial hardship, better say. We would need data about financial hardship that people living with rare disease are facing.
Excellent. The second?
Second sentence, please have a look at the WHA resolution on the economics of health for all that also tackles dimensions of public policy that are not in the health sector, but that answer to health-related issues. Thank you.
Excellent. Thank you. Joseph? You muted.
So without data, there's really no accountability. So I agree with Claude. And if I was given the opportunity, I would sort of mandate national rare disease registries with standardized data. And I think that's what GAPRD will need to do. It's data, data, data.
Thank you very much for bringing this very important aspect. Lou, would you like to give your 2 cents?
Yes, no, I agree with Joseph and Claude. The problem I'm having is reconciling the numbers on access to essential medicines, where the drug lag is 9 years, and then I see that Kazakhstan has hundreds of drugs on the RD on their list. Well, how many people are getting those? So I need more data on. I mean, again, I'm biased by the most recent cell and gene therapies, which are very expensive and so on. But we've had orphan diseases for a long time, and I don't have a good sense of what the access lag is, what the cost is. And so I'd want to run the simulation. What are we talking about? Because we are talking about adding more costly cell and gene therapies, but we have a lot going on already. And I just I don't have I needed to see the numbers. Well, what was in that? What was Kazakhstan actually covering, and what was the utilization level? So we do need some more information as part of running this global action plan. Yeah.
Excellent. Thank you, Lou. And Sue, what are your recommendations?
Two things. Firstly, pay what you can, the tiered pricing, crucial. And the second one, leave no country behind, not just poor countries, but small countries. So regional collaboration is essential. There is so little done about rare diseases in the islands, the small island states. More needs to be done. Thank you.
Thank you very much. I'm going to close down that panel discussion, but we have a few questions that you may want, and the presenters as well may have to respond. So I hand over to Alana before closing this webinar. Alana, can you lead us to some main questions?
Yes, happy to. Thank you, Alexandra. Yeah, I see we have a few minutes, but there's been some really good activity in the Q&A section as well as in the chat. So I'm going to point to one of the questions that was asked a bit earlier, but a question from Kai Hongfua. He said, I'm sure the financing will be very political. What is the situation regarding countries using cost effectiveness evidence to get indicators of clinical outcomes? I'm wondering if anyone has any thoughts on that one. Any of our speakers?
I can say that Kazakhstan is attempting work in that direction. So the creation of last year, Republican Center for Rare Diseases is specifically tasked with methodological support of Ministry of Healthcare's financing decisions to cover this or that particular medicine, is guided by now cost effectiveness evaluation done by this working body, by the Republican Center, which conducts direct patient monitoring, like lab results and verbal, or written physician evaluation reports every 3 months. So every 3 months, information is collected on all patients who are in Kazakhstan's registry for rare diseases, patients who living those diseases, to see over time and observe long-term cost effectiveness of treatments that are covered.
Okay.
So I don't know how it will progress, but at least the work has started.
I would just add that at the core of every cost effectiveness model is a disease outcomes model. So and it's in there. So you got to see it. It's driven by that. So as we just said, it's nice to update it over time with data. But like joint clinical assessment in Europe, they're trying to speed up access and make a more rapid assessment. And I think that's part of the drug lag. And so I think we do need, it can be done more rapidly because we're all using the same data. Okay. I mean, the trials are done in US and Europe, and then people model off of that, and then they do a projection, and that data is used all over the world. So.
Okay, yeah, that's really helpful. Thank you, Lou and Ainur, for those answers. And Lou, while I have you, I'm going to put you on the spot because there's another question that was directed to you from Graham Stat. So it says, I wonder if the US's most favored nation policy is going to undermine the feasibility of a tiered pricing framework.
I was just getting ready to thank Graham for his many good comments about life cycle approach and everything in the chat. But well, I mean, I think the basic thing is the U.S. is, since the U.S. finances 50-60% of R&D, companies are not going to reduce their U.S. prices to European levels. And the question is, well, what do we, and we've seen the UK say, well, okay, we'll pay more for cancer medicine. So the question is, how are the other countries that are above 60% of the GDP of the US, what are companies going to do there to put pressure on them? And I think it's unknown, but I think it's still going to be tiered pricing. They're not going to come up to US price levels, and US is not going to reduce their price to that level. So it remains to be seen.
Okay, amazing. Thanks, Lou.
Well,
That's
Sue looks
really...
like Sue might want to say something. I think she looks like she might. Yeah.
Okay, that's really insightful. Thanks, Lou.
Yeah.
I think we have maybe time for one more question, and then the rest we can try to answer in writing so we can follow up. But maybe I'll go to the question from Zor in the chat. So if rare diseases are mostly genetic and extremely costly to treat, why don't healthcare systems start by implementing early detection approaches, e.g. within the first 12 weeks of pregnancy to be covered by health insurance? And I think we've kind of talked about that, but if anyone wants to speak to that point specifically, I'll see who wants to jump in.
Well, I think Sue commented on newborn screening, and certainly for some of these diseases, it's better to catch the spinal muscular atrophy in utero than to wait until 12 months. So, yeah, we want to do newborn screening for these, and then try to, if we can intervene sooner.
Yeah,
I can add that.
There's not just newborn screening, but there is, in the Middle East, they also do genetic counseling even prior to pregnancy. And then there are things to screen for in pregnancy. But that's probably going to be something that happens in the high-income countries, because all these, genomic, what have you, things that people will discover early in pregnancy are going to be very high-cost procedures, would be my guess.
I was going to add that Kazakhstan does genetic screening on national, on all, entire nation, 20 million people is the total population. But newborn screening includes phenylketonuria and hypothyreosis, two particular diseases, but not all rare diseases are identified through those two screenings. So what has been happening is training the capacity of pediatric neurologists across the country who are coordinated by some national tertiary care center. And so identification of children through primary care networks who are able to capture and refer this is helpful, I think, as a kind of learn as you go approach. So not everything is detectable through newborn screening and during pregnancy. And also genetic counseling and pregnancy during consultations during pregnancy, even with confirmed suspected disease that will be debilitating for the life of the fetus and future child, does not, it's ethical question. So regardless of consultations, women choose to give birth to such children. So it's a discussion in action.
It's a very complex discussion from an ethical point of view. Yes. Thank you very much. I think we should close down that meeting. Thank you, Alana, for the great moderation of the overall event and the preparation. And the last point, actually, just remind me how much rare disease, it's about an holistic approach. It's not only about looking at access to treatment, but it's also looking at data, knowledge, access to diagnosis, newborn screening, etc. So I'm going to close down. I would like, first of all, to thank you very much, all our speakers, the panelists, and everyone who participated today. Really, your insight and all the data that we have started to collect help to deepen our collective understanding on how health financing and social protection system can better serve people living with rare diseases. And I would like to highlight three main thematics that really came strongly from the discussion. The first one is the importance of equity by design. It means ensuring that rare diseases are not an afterthought, but a structural component of universal health coverage. The second point that came out was the need for innovative and concept-appropriate financing solution. And I think all the different study and cases really I illustrated those solutions. Notably from national funds to regional risk pooling and international procurements. It's something that could be also explored further. And finally, there was the call for stronger global coordination and data-driven to ensure accountability. And this is what we hope that the forthcoming Global Action Plan on Rare Disease will deliver. So this discussion, again, is not the end. There would be a report that is going to be issued jointly by P4H and Rare Diseases with a set of conclusion and recommendation. But again, it's a step toward a global consensus on financing rare diseases care in a sustainable way and, if I may say, fairly way. So ADI, together with P4H and our partner, we will continue refining our analysis and recommendation, and we will integrate the discussion of today. So on behalf of ADI and P4H, thank you again for your time, engagement, and commitment to this shared cause. We are looking forward to continuing this dialogue and building a world where people living with rare disease are better included in every national health and social protection system, even in small islands like Sue pointed out. So thank you very much, everyone. And right on time, by the way. So excellent moderation, everyone.
Thanks, Alexandra. Thanks, everyone. Thanks to all the panelists and the speakers.
Thank you.
And thanks, everyone, for joining.
Bye-bye.
Bye.